only 2% of a population, when we know the needs somewhere between 25%, maybe all the way up to 50%, there's an awful lot of people walking around with those unaddressed mental health needs in the mental health space. And so I don't think you can even have a conversation about measurement-based care unless you start to address like the access, because that's really the start of the journey.
Chris Hemphill with another Meeting of the Minds. We are recording live in partnership with the Future of Mental Health. And what we're addressing today is a continuation on our conversation on measurement-based care. You might recall or might have seen or heard the episode that we had with Dylan Ross, who is the Vice Chair for Measurement-Based Care at the APA, American Psychological Association. In that episode, we focused on the ability to impact patients with depression and anxiety, and ultimately the poor adoption of these programs, what's led to that, and how to introduce these programs in a way that doesn't drive burnout to an already burdened staff. But we want to drive the conversation deeper, and we want to bring diverse voices and stories and perspectives so that there's a deep understanding of the many aspects around measurement-based care, why it's important, and the types of results it can drive, but also the hurdles that you might face while driving those results. So to help us out with that in the best possible way, we have Melissa Reilly, who is the Chief Growth Officer of Behavioral Health Services at Evernorth. Melissa, hello.
Hello, thank you for having me.
Really appreciate you coming in and joining us today. What we were thinking and hoping that you could get out of this were some key learnings around measurement-based care, how to tailor measurement-based care initiatives to special populations. So taking that general conversation and driving it deeper to more specific and unique needs that people face. There's one size fits one in healthcare. Overcoming challenges around adoption, focus on health equity, and understanding the economic impact and how that evolves with measurement-based care. Does that sound like a fair way to kick off the convo?
It's one of my favorite topics, so I'm excited to dig in.
Can you tell us your story and your background and why the measurement-based care conversation is important to you?
Yeah, absolutely. So I'm really privileged to have spent my last 2 years with Evernorth Behavioral Health in a growth role, kind of looking and getting the chance to think about what should the future of behavioral health really look like. And in order to understand and define our future, it really helps me to think about like my past and my personal motivations for getting into the behavioral health space. My behavioral health journey started with my family and with my nephew. And we were actually so fortunate because my sister was such a caregiver and such an advocate for my nephew Matthew that she got him enrolled in an early childhood education program at Yale. And so we got some of the absolute best ABA therapy out there. And I actually saw how with the right goal setting and the focus on outcomes, you could see incredible improvement. And I compare it to other friends and family members that might have experienced ABA. And I, think about some circumstances where a friend was really having a challenge getting more than just a babysitter kind of in her ABA experience. And so for me, that was my real world experience with special populations. And when I think about Evernorth being an innovative health services company and our ability to touch over 26 million lives, every day I think about Matthew and that it shouldn't be a coin toss that determines what level of care your child gets.
This is something that excites me about everyone who I've been working with in the mental health space, is that the spark often comes from very personal scenarios. And really appreciate you sharing your story and how you've kind of mobilized into a position where you can focus on a population of 26 million. As Chief Growth Officer of Behavioral Health Services, can you define what that focus is and like basically how you fit into this role?
How we have been defining measurement-based care is really the focus on quality outcomes instead of just the narrow focus on the provision of services, right? Okay, so let's say that in like common language, right? As we look across the population, we want to make sure that the care that's being provided actually helps make someone better or improves the quality of their life instead of just paying for a service that is rendered. And I think for us, the biggest challenge is considering the multiple stakeholders that actually have different incentives that walk into the equation, right? So like, I'll give you the example, my personal example, right? So you have my sister as the parent, oftentimes the insured, not always the insured, right? You have a health plan or a health services company that might actually be paying for it. You have the provider, and then you might have the patient, which might be like the dependent, not necessarily the insured. And sometimes you have technology and enabling companies kind of in the middle. And so you've got all these stakeholders and sometimes different layers. And at the end of the day, the outcomes that all may want may not actually be aligned. And so for us, that's been the most unique part of the entire journey in measurement-based care, is like, how do we create that stakeholder alignment through partnership that incentivizes all parties to have the right behaviors?
As Chief Growth Officer, what in your day-to-day, what's your role in that?
My job originally was to spend a lot of time looking at like how we introduce Evernorth to the market. But now, one of the things that I actually spend a lot of time on is starting to vet partners, spend time with our partners that we believe help us enable and unlock measurement-based care at scale. I also spend a lot of time with our clinical teams and our product innovators looking at like, how do we take down barriers in the access to care? So when I started in this field 20 years ago, there was a little bit of stigma. Like, nobody grows up being like, hey, I really want to work at a health insurance company. And certainly I, like in my law school days, wasn't like, yes, I can't wait to get into healthcare. But I kind of like always saw it as a space where there's these deep problems that can still be unlocked, right? And for us, measurement-based care really is. And so you kind of asked me, like, what do I get to do to be able to like address this space? Well, my job now is really looking at the point of view of all stakeholders. And it's really about how do we take down those barriers that would stop people from getting that quick access to care, right? And I mentioned like a little bit of the stigma in healthcare. I really do believe that there are people out there that think those of us that are affiliated with like a Cigna or a name of another payer, that we spend a lot of time thinking about how to stop and block access to care. And as I like to say, I really, in my week, I can't think of 1 minute where I'm actually focused on how do I deny care. The majority of my time, 80% of it is really spent on knocking down those barriers and thinking about how to enable that quick access. And there are so many barriers from that quick access that need to be removed for this to be really successful at scale.
We're talking about measurement-based care, and we're talking about these special populations. Could you give like a very, very basic definition of measurement-based care and how it differs from a general population to specialized population?
Yeah. Okay. So I actually think in behavioral health, you almost start with the presumption that everyone has anxiety and depression. And in part, I'm not clinical, right? So maybe clinicians would disagree with me. But if you think about it from like a very logical perspective, right? And you think about the elements of good behavioral care, you really start with someone raising their hand or, having their hand raised for them, that there is something going on, and then they consent or sometimes not consent to an assessment, an evaluation of health status. And then based on how they talk about what's going on with them, resources are offered, oftentimes therapy, right? That then is used to say, is what we're doing, us having this conversation, really helping to improve someone's health outcomes or make someone better, right? And so oftentimes, especially in the commercial space, you don't always see these severe mental illnesses. They're not like always apparent, right? And so there is this presumption of baseline, that people can function, right? When we're talking a little bit more about severe mental illness, we go up into a lot of those higher levels of care. Oftentimes people will present inpatient or at the hospital, the emergency room, right? And certainly we have solutions that are, seeking to address that. But in behavioral health, you really do have a lot of opportunities to intervene and meet someone oftentimes before they escalate into that higher level. And you don't always know the health status of someone in that therapeutic relationship until you start to dig and learn a little bit more. And so sometimes accessing those special populations or finding those and those rising risk levels are much more challenging than we would see in the medical space.
One thing that I don't think is heavily acknowledged is that a significant portion of mental illness that follows people throughout their lives. These are things that manifest in childhood that go unaddressed for decades.
Absolutely, and the numbers really start to tell us the story, right? I mean, 10 years ago we were debating, is it 1 in 5 or 1 in 4 people that have a mental illness, a mental condition, right? We've seen through the pandemic that number starting to exacerbate a little bit, right? And then you look at the percentage of the population that's actively seeking that care and accessing that care. I'll use a commercial space number. We'll look at like kind of our EAP. It's supposed to be that baseline for people, that want to access care. And we look at a typical EAP engagement somewhere in the neighborhood of like 2%. Right? So while we know there's other places where people are starting to access that care, right? If only 2% of a population, when we know the needs somewhere between 25%, maybe all the way up to 50%, there's an awful lot of people walking around with those unaddressed mental health needs in the mental health space. And so I don't think you can even have a conversation about measurement-based care unless you start to address like the access, because that's really the start of the journey.
I wonder about the perhaps a region or area or group of people that hadn't been under measurement-based care, MBC, before, and what were some of the challenges that was leading to that drove a change to bring them into a program?
Yeah, so I would say there's about 4 areas right now that we're very acutely focused on. Autism is top of the list for us. I can go a little bit deeper about some of the really interesting things that we've been starting to look at in that space. Kind of adjacent to autism is children. We feel like there's not enough done to really help children right now. And coming out of COVID, it is just so heartbreaking to see how many children, how many families are just struggling with like loneliness, lack of vitality. And I just think there's so much more we can kind of do in that space. We've also looked at, and this has been really interesting and filled with a lot of spreadsheets, we've looked at how through our PBM, our pharmacy benefits management, you can see a lot of things that come in through like prescription drug utilization. And so we've done a lot with like trying to look at, can we see unmet behavioral needs coming through pharmacy utilization where you don't have a behavioral health visit. And we're so lucky because we have a really unique data set that we've been able to do a lot of publishing off of, which is fully integrated medical, pharmacy, and behavioral. Some other areas of focus for us, some areas of comorbidities. We've been doing a little bit of dabbling into like oncology, looking at mental health and the cancer journey. As a cancer survivor myself, I can count on my one hand how many times my mental health needs were asked about, and this was only about like 15 years ago. So we think that's a space that deserves like a little bit more attention. And we're also leaning into people kind of in that rising risk level, those that would have more severe mental illness.
Appreciate you sharing that. And honestly, we do talk a lot about primary care integration, behavioral health integration in the primary care setting. And I mean, that's because 60-70% of mental illness issues appear in that primary care setting, but there's such an unmet need among around specialty care and mental health.
For sure, for sure. It's been so nice as I've been kind of traveling on a lot of these conference circuits. A lot of friends have been continuing to like introduce me to different academics in the space, and that really helps us kind of gather these different perspectives. And I want to just kind of bring in for a moment as we think about some of these special populations, like the role of the provider and just how important it is to kind of build that trust between like the patient and the provider. When I speak with providers, and I do a lot, like, I'll interview therapists or, talk to my own therapist, and I'll ask them, like, or they ask me questions back, like, do they say, do you not feel like I'm actually practicing measurement-based care today? And I think so many of them actually are. And I can see a lot of their great work kind of evident, in the care that they're giving. Like our providers, for the most part, are, fantastic humans that are in it for a really great reason. I think we're going back to what we talked about a little bit earlier as it relates to some of these special populations. I don't think it's not that our oncology providers don't want to address mental health needs, but as you look at like how their workflow goes, like there's not always these opportunities either in terms of time or their EMR for them to ask these great questions about mental health. But I have to say, I am super positive, optimistic, you choose your word, that things are getting better.
Was there a scenario, I guess, in your tenure or that you've seen in which there was no measurement-based care in place and you gradually introduced to that population and providers?
Yes, and we continue to be really focused on this work as well. So we've been working on a collaboration right now, which takes an employer, it takes an innovative technology company in the autism space, a really future-forward provider group, and we're actually all collaborating around the use of the technology in order to return back some really innovative data in the measurement-based care space for autism. Now we have a technology enabler that's actually rolling during the therapy session with consent that allows us to look at are the goals achieved? And there's a lot of people out there that might be listening going, wow, that is way too big brothery, right? And I think, hearkening back to my law days, right? There is consent all through this, right? We have the provider, the parent, the child, like everyone is consenting to this happening, and what it actually does is removes this unbelievable amount of administrative burden on the providers who are giving that care. And one of the things I think it really helps to do is scale the return of outcomes back faster. And our hope is that although this is really, out there and progressive, our hope is that this will be more commonplace and we will learn from the measures that we collect, and that will continue to propel this space forward.
Let's talk about learning from measurement-based care. What have you started learning about populations, and from a practitioner perspective or strategy perspective, what's changed now that you're seeing these checkpoints and measuring these various data points about people's visits?
Yeah, well, I think, first of all, I don't want to create the perception that we weren't collecting the data before. I think what we have really spent a lot of our time analyzing, like I talked about that really great integrated medical behavioral pharmacy data set. I think what we have just continued to double down on is there's such a lack of standards in terms of like, what is the definition of good? Like, let's look again at our like autism population. I love this example. One of our partner was kind of sharing this with that. Tying your shoe, the ability to tie a shoe is actually one of the measures that's collected, right? And I think to myself, when I look back to my nephew or even my own children, do I really value the shoe tying? Like, is that a goal that I would really want my child focused on? Or is there a goal that might be being able to sit near your desk or complete your paper, right? As you or even be able to be in your classroom and even assisted, like make it through the day in your classroom might be a goal that I'd really want to be focused on instead of the shoe tying. And so I just think being able to see the data and roll around in it on those spreadsheets is just so enlightening in terms of, are we focused on the right things? Is our shared definition of a success all aligned? Like it is way too hard to be able to collect back all these measures, which now we know many of the provider groups are able to capture and share, but it's way too challenging to be able to scoop them all up and do something meaningful with it. And I think there's also these perceptions that we're going to then use that data to deny care. And I think, again, we're really focused on access, not the denial of care, but that perception is out there, and so that really starts to create that reticence around some of the sharing.
How do the conversations around driving adoption of these practices happen, or how do you influence the adoption of
Yeah, they're collaborative. They're really collaborative. Where I've seen a lot of success is like actually kind of putting our cards on the table to say, like, what are some of the puts and takes, right? So I realize I'm now asking you to capture more data than you would have, or use a different tool, a software than you would have before, right? And there has to be incentives exchanged for being able to do that. And I think, there's a receptiveness to the upside incentives, and ultimately there's also got to be, sometimes downside incentives if those incentives, if those measures are not achieved. And so those conversations are really delicate. They're partnership conversations. They're not like vendor contractor conversations. They're very much more done in the spirit of partnership, and often with multiple parties at the table. And I just am so excited for that. I just feel like it really changes the dynamic that we're all kind of in this together trying to make it better versus this adversarial, we're going to deny the care if you don't do it that way conversation.
It's a matter of taking taking conversations and taking approaches that might have been adversarial in the past and establishing this isn't just rules coming from on high. There is there's a return on the effort that you put into
Absolutely. And it really feels like you're changing years, in some cases hundreds of years of like established contracting rules of engagement, right? Because you're looking at innovative contract measures and you're sharing, well, I can do this. Today I'm able to do this. I can't get all the way to here where I know you want to go, but let's start here. Let's get that data. Let's see how that flows, and then let's pick up some additional measures. We've been really excited about trying to capture time to care more at scale. And you would think that would be so easy, but even think about it. When does the watch start? Does it start when the person calls in, chats in, Skypes in? Is it, when they have a claims issue? Is it, when does the watch end? When they have the first appointment, the second appointment, or the third? And we've got some great research that says, therapeutic alliance and medical cost savings can actually be enabled in some conditions with one visit. But in our early research, we had, really leaned more towards, it's the third visit that starts to make the difference. And so even as we've refined some of those analysis and sliced and diced the population differently, we've seen more savings be able to emerge in some of these special populations. And so that's really helped us hone in on, for our health plans and our employers and our clients that we work with, we can go after this population. It's kind of made behavioral health less of an art and more of a science, and I'm really cheering for that.
Excellent. And when you talk about being able to enact a difference for special populations, there's a huge story there because a lot of the focus is on the mild to well population in the first place. And it just seems like a lot of other issues kind of fall by the wayside when it comes to the innovation and different things that folks are talking about. There's just not the gigantic amount of effort that there should be there. I'm curious about how you see measurement-based care evolving over the next, call it, year, 3 years. Like what are some of the things that you see in the future that are going to help in driving a greater adoption for measurement-based care?
Yeah, a friend of mine was talking a little bit about like the high trust movement and how great like the high trust movement has been. For technology companies, maybe some would disagree with that, but it creates like a set of standards around what companies must do for their technology to be safe. That's probably the easiest way I can explain high trust in a minute. When I think about the behavioral health space, where I see this evolving is I do think standards will start to emerge. Like there's going to be a natural forcing function around standards, and we're hoping to drive that, but we know we can't drive that alone. We need that partnership to be able to do that. And then my hope is that there will be more interoperability, and I'm hopeful that will come through. A couple of my colleagues were just at, a whole conference with the NCQA all around FHIR-based standards,
Okay.
right? So I do believe those standards or those rails are going to be coming. That'll make it more easy for us to send measurement back and forth to each other. But right now we're still kind of dabbling. We're all like, do you like the PHQ? What about the GAD-7? What about this new measure over here? But we've not all put our hands in the middle and say, like, these are the standards we all should be using. And I think as those standards emerge, this gets a lot easier.
The final thing that we do on our episodes is to give you a superpower, a magic wand. And this allows you to change one aspect. It's a super powerful to change one aspect, but then it's done. So you have to prioritize and choose one aspect of how care is delivered.
Yeah, I've been thinking about this one. I mean, I like my magic wand to have lots of waves. But I think where I would love to just go is I would just love to have more capacity to be able to ingest more measures more quickly from more providers, right? And we know right now that that continues to be a limiting factor. That lack of standards that we just talked about means we can't pick them up from each of the providers as quickly as we would like. And that is just my goal, and what I focus on every day is how do we ingest more of that data more quickly, because understanding that data helps us make better decisions and helps us get people to the care that they need more quickly.
It sounds like you're coming from a perspective of what can we learn about the situation that people were in when they came and sought care that we can use to then make better decisions and improve the process later on.
Absolutely, because it's really about making the lives of the humans that we're serving better, not making it harder for them to get the care that they need. And in the mental health space, you need more data to make those better decisions.
So I think that people listening, some of them are going to be shaking their head just like I am, like up and down, like, yeah, okay. So of those people, that audience, what's the best way for them to keep up with you and your conversations and what's going on?
Yeah, I would say just please get to evernorth.com. There's lots of ways to get in touch with us for more information and some of the publishing that we're doing around like the really interesting data that we're able to collaborate on our partners to get. So thank you so much, Chris, for the questions, and I really enjoyed this.
Croy, I really enjoy it too. Appreciate you sharing so much about what you're doing. And for everyone else, we'll see you next time.